And now it's my pleasure to introduce Jill. Are you mic'd?
Yeah, Mike.
Okay. So we're going to do the interview. So, so can you give us a little bit about your educational background?
Sure. I went to college in upstate New York at Cornell, and then continued the Cornell thing, did med school, New York City, Cornell for residency, and then finally got out of there to do my fellowship out here.
Okay.
8 years, come June.
So what do you do out here?
Oh, it's a great question. I am an assistant professor in the Infectious Diseases and Global Health Division. Oh no, Division of Infectious Diseases in the Department of Medicine at UCSD. I wear a bunch of hats. I do research mostly in HIV prevention using pre-exposure prophylaxis and various vulnerable populations. I am also a physician at the Owen Clinic, the Mother-Child Adolescent program. Dabble a little over at the night clinic with you.
Last night.
That's good. Yeah, last night. That was fun.
Yeah.
Miss all our friends from there. I see a couple of doctors that are there too. Yeah.
So tell us how you got to this path and what drives you to do what you do.
I ask myself that every day.
Yeah,
I told him I was going to say that. No, I think it was pretty clear to me that once I'd chosen infectious diseases, it felt like HIV and particularly prevention was a natural fit for me as someone who really wants to help and support, champion the underserved, and as much as we can do things before they happen, as opposed to react. I sort of fell in love with that idea of prevention. And what drives me, seeing your face every day. No,
every
just
day.
Yeah, right. That would be too much. No, just I think seeing people benefit from the work that we do, and I don't think I've ever worked with more caring colleagues, which is really inspiring.
Cool. And today you're going to give us a CROI review series on
as best as I can. Yeah.
All right, take it away.
Thanks. All right. I feel a little snarky this morning because I'm a little tired, but hopefully we'll get through this together. This was going to be about HIV. It was actually HIV drug trials. And as I was going through the slides at 2 in the morning, no, I'm just joking. I did this earlier, looking to see if Lucas is here or Craig. No, I thought that because Lucas is presenting in a few weeks, I think he'll cover the drugs and some of the newer drugs. So this is a little bit on HIV treatment, but it was some of the posters and talks that I thought were really interesting to bring back, and then the majority of the talks on HIV prevention. My pronouns are she, her, hers. I'm an investigator in studies where drug is provided by Gilead. Okay, so the outline. I think one of the big news out of CROI were the Atlas and Flare studies. So I'm just gonna go over them a bit. Those are using our long-acting injectables, which patients are very excited about, because I work with our adolescents, and they often, and our children. I hear I know that they've had tough times with drugs in the past. The study of Biktarvy in them, our newest drug, actually in children. A little bit about TAF versus TDF in women, and then see, now I'm going in a different direction. This was obviously a very hot topic last year, so I just want to talk a bit about pregnancy outcomes with the INSTIs, and then just a really cool study of point-of-care viral load testing. And then for HIV prevention, we'll also talk about the big trial that came out of CROI Discover, a little bit on toxicities, PrEP persistence, which is a really big topic right now, immediate PrEP, electronic, that was what I was looking for, electronic medical record-based algorithms, and then a little on U = U. So, okay, so diving right in. So Atlas was a 48-week study of individuals switching from suppressed therapy to cabotegravir and rilpivirine long-acting. And big study, multi-centered, randomized, open label. So people had to be on stable ART, and it was either their first or second regimen, viral load less than 50, and no previous virologic failure. And there were 616 people. So, this is always to me the part that I wish were different, but there's always the oral lead-in. So oral lead-in for 4 weeks, and then those people went to the cab, rilpivirine injections, which were done monthly. Yeah. Okay. Sorry. Yeah, monthly. And then the group that was already on stable ART stayed on their ART, and then they were allowed, the comparator arm could switch into the intervention arm, or the injectable arm after week 52. Like most of these trials, the primary endpoint was the proportion of RNA greater than 50 copies, in an intention to treat with the 6% non-inferiority margin. So this is a non-inferiority study. They weren't trying to show that it was better, just that it was as good as. Sorry. So just some of the demographics here, pretty nice, wide range. 42 is the median age, 23% Black, 68% white. And I do want to point this out because this is something they really spent time on. 33% of the individuals in the study were female, which is often lacking. So okay, so the big news, and it works. Just looking at virological success, virological non-response was the primary endpoint. So you can see there's 1.6 versus 1% in patients, and then we can talk about virological success, 92.5 versus 95.5, which is not statistically different. And then here is looking at the non-inferiority margin, where remember they said it was 6%. I don't know how that statistical number came about, but it's well within that range. And then for the secondary endpoint, it's within a 10% margin. Again, not really sure where the margins came from, but I know that this is statistically valid. Basically, and then I'll talk about the virological failures in a second, because that seemed to be a big focus for people. I think a lot of people knew that this was going to work well, but for the people that didn't work, what was going on? And so the drug-related AEs were grades 95% were 1 or 2. There were no serious adverse events. I think what's always a big issue with injectables is, are there, the injection site reactions, are they a big deal? They called them mild. I don't know where the mild came from. I do know that as we were supposed to be an Atlas site, and this was a big issue in the first study. But again, most resolved within 7 days. So if you're doing this monthly, maybe you forget after a little, and then you come back in a month. But no major events. And then I'll just tell you about FLAIR. So FLAIR was for naive patients. This is the study we were supposed to be in, my bad, FLAIR. So these are individuals who come in naive to medications, get placed on dolutegravir, bacavir, 3TC, Triamec, and they had to have RNA greater than 1,000 and no NNRTI RAMs. And there were 629 people enrolled here. And again, like the other study, a 4-week lead-in with the oral version of the cabotegravir and rilpivirine, and then going to the injectables, or the other group that was going to continue on the dolutegravir, bacavir, 3TC. I think what was exciting to see, since we do see a lot of K103s, those were permitted in the study. And there were a few other things that you could do Oh, right, if you had intolerance to, if you had an HLA-B57, so you were intolerant to Bacavir, you were permitted to join that way. Again, same endpoint, greater than 50 copies, 9% non-inferiority margin. A little bit different here, a little more male, a little fewer Black, and the median age was younger. So again, this does well. Virologic non-response, 2.1 versus 2.5%, and then the virologic successes, almost 94% versus 93%, which is not statistically different. And right, I forgot to mention there is no virological data, and those are people who left the study early, and they put them here. And then again, we see these look even better, the non-inferiority plots, where they really fall close to the margin here. So these, these really work just as well. Okay, and I'm gonna show this on the next slide. So, or I'll show this on a slide. So we'll talk about that in a few seconds. And this is just about plasma concentrations, and really it's just to show that they were very well maintained over time, and it's for those who know what the oral regimen should look like, it's very similar. So the concentrations looked how they were supposed to look. I think part of this was when the study was in phase 2, they were injecting, was it every 2 months the first time around? I'm looking at you. Or it was either every 6 weeks or 2 months. Latte was 2. Right, so in the 8 weeks did not, thank you. And the 8 weeks did not work. So it didn't work as well. I thought it was not statistical. I thought it was bad. Well, they ended up changing. Well, thank you, Connie. So they changed around the regimens a little bit to make it so that it was once a month and slightly higher dosage. So anyway, it looked the way it was supposed to look with the oral regimen. And again, the injection site reactions were the most common, and they resolved within 7 days. There was one serious adverse event of a monoarticular arthritis. I'm not sure how they decided that was related to the drug, but
they have to achieve virologic suppression.
You cannot. I didn't hear any of the question until you had your microphone. Sorry.
Did they have to achieve virologic suppression during the lead-in period before transitioning over?
No.
Did they mention that?
No, it was 4 weeks and then over. That's a great question. Let me just make sure. I'm pretty sure it was exactly 4 weeks. Yeah.
20 weeks of dolutegravir. Everyone got 20 weeks
yes,
of dolutegravir,
right.
Bacavir, and 3TC.
I didn't say that part.
Yes,
I'm sorry.
they had to be virologically suppressed
right.
before they were randomized to the 2 arms.
Thank you. Yes, I skipped right to here. Yes, right there. Had to be. Thank you. Okay. So this was, again, some of the big news that I think people were a little bit perplexed by. There were 6 total resistant mutations, 3 in each study, and 5 of 6 came from Russia with the HIV subtype A1. And this was really, and this was very puzzling to a lot of people. In FLAIR, 2 of the mutations were the Q148R integrase resistance mutations. And they looked at all of these individuals, and they had drug levels that were lower on the distribution, but certainly within the range of what other patients had experienced to maintain suppressions. And I quote Paul Sachs, who says, "A mystery." I don't think anyone, I think it's not really clear why these people failed, and I think perhaps it's a little concerning to people. Obviously, very small number, but nonetheless, they did fail. Lalo.
On the Atlas study, it looks like the analysis of the virological failure, it was a retrospective analysis on the stored samples using an archive genotype. And most of those, 2 out of 3, have baseline NNRTA RAMs.
Mm-hmm.
So I don't know if you will agree about that the negative predictive value of an archive genotype is imperfect. And one practical approach is, if you're planning to do this switch, perhaps consider an archive genotype, looking for those RAMs before. And on the flare, it's a completely different interpretation because
Yeah.
all of them, they have baseline, I'm sure, pan-sensitive genotypes.
Right.
And then they develop emergent resistance to these new integrase inhibitors, which you wonder about the potency and why.
Yeah, no, I think that's really important that this is, you know, you're right, archive versus what emerged. It's still, I think there was a lot of fixation on this. To me, you know, still a tremendous success in these. But of course, I think to me, what's really concerning about these two is these are people in a study who are being, paid to come in. What does this look like in the real world when we lose people, when, people potentially are doing this at longer phases? What kind of resistance will we see emerging? So, I mean, this certainly worked. I think this is really exciting. We have a new drug that I'm not sure. I'm looking at the people who know when FDA approval occurs, probably sometime soon, next bunch of months. Oh, okay. Okay. All right. So, I mean, this is really exciting. Yeah, sure.
Comment.
Please.
So obviously the mystery is of concern. There are two issues that a company is looking at in greater detail. One is this possible association with the subtype A1.
Yeah.
And digging further into what issues may be associated with different subtypes of HIV, because this was done in two settings, a big international setting and a big US study. So with the flare, the screening genotypes that were done were not single copy assay kind of genotypes, where deep sequencing. So they're going back to the baseline and looking with deep sequencing about whether there were actually integrase resistance mutations present at the time the patients started on study.
Okay.
And they're also looking at the time point where the dolutegravir 20-week switch over to the injectable drugs took place. So there's a lot more data that'll be coming out of that study.
But still they're moving forward with the approval. It doesn't affect the United States. Okay. This is important too, obviously, because, who actually wants to do this? I sort of brought up, if you have an injection site reaction, is that really worth it? And all of those things. This was so well received by participants in the study. So Atlas, where they were I always think that patients who've been taking this oral medications for a while would be more interested in going to this. And of responding participants, 97% said that they would. It was just one single question, but would you continue taking it? So 97% versus 2% saying they'd prefer the daily pills. And then in flare, where, these are individuals, yes, they got the 20 weeks of the oral, but these weren't people who were on oral medications for a very long time. 91% said they preferred that to the oral regimen that they experienced, and 1% preferred the oral. So I think that speaks very, very loudly about, what patients want, and that this will be something very well received. I still think there are a lot of things to be worked out about how this is going to be rolled out. Remember, patients can't inject themselves because the quantity is too large, so it'll have to be done in some sort of, healthcare setting. Will it be in pharmacies? Will it be in, clinics? How do we guarantee that they come back for their 1 month? There is a little bit of wiggle room there, but I think there's still a lot of things to consider in the real world, but still very exciting. Okay, so I just wanted to talk about this, knowing the history of what pediatrics has gone through. And when I first started working over at MCAP in 2012, to see that they were still on seemingly very old regimens, PIs still liquid based, because there were no alternatives for them. That Biktarvy is actually studied in adolescents and children here. So this is a phase 2/3 open label multi-center study. I believe it took place in Thailand and Africa and the United States. So they had to be, these were suppressed, no documented resistance to FTC, tenofovir, the INSTIs. Let's see, and the primary endpoints were steady state PK parameters, weeks 2 or 4, safety and tolerability. And then secondary endpoints, safety, tolerability, and antiviral activity at weeks 24 and 48. So you have 12 to 17-year-olds and the 6 to 11-year-olds. They do have to be above a certain weight to do this, but 25 kilograms in children, that's pretty good, but ages 6 to 11. So starting pretty young, 50 and 50 of each, and pretty nice distribution of what we're seeing here. Very high mean CD4 counts. These are children though, and adolescents who do often have higher levels. And so these are the week 24 and 48 snapshots. Couldn't look better to me. I mean, obviously it's small group of people, but at week 24, 100% of people had viral loads, less than 50, and the adherence rate, and I'm actually, I think it was, I actually don't know how they measured adherence in this. So I apologize, but it was fabulous. I mean, obviously it reflects these results, but I apologize. Let's see if it comes out in any of these things. Yeah. Okay, but the safety, very well tolerated. The most common things that I think we also are seeing in some of our patients, insomnia and anxiety. I don't think we've gotten to weight gain yet here, which I'm not going to cover, but that was a very hot topic at CROI. That may be something that someone else covers at some point in another, when they do some CROI stuff. And 2% serious AEs, but they were grade 2, unrelated abdominal pain and lung abscess. So basically in children and adolescents, this was well tolerated with a high rate of adherence and maintained virologic suppression. So very exciting results for our youngins. Since TAF is now one of the big things we're looking at, what is always left behind, or who are frequently left behind, are women. And in a lot of the studies where TAF has been used, women were very underrepresented. So Melanie Thompson did a nice, a pooled analysis from 7 randomized studies comparing TAF to TDF. And I think, not surprisingly, the numbers look very similar in terms of virologic response in both treatment-naive and virologically suppressed individuals compared to what the men have looked like. No differences there. And here is the non-inferior. She looked at non-inferiority, and that stays, that does well too. And of course, I think this is the big. I think we all know that works very well. I think the big issue is what happens with renal markers and bone markers. And basically the big finding here is that both in treatment naive, in treatment naive, women initiating, so in both initiating and switching, they had less tubular proteinuria as seen in retinol binding protein ratio to creatinine and beta-2 microglobulin, and again, similar results as the men. Oh, I thought Lala wanted to say something. And I think what's important to note is that no participant on TAF developed a proximal retinal tubulopathy. And then again, I think a really big issue that affects women, although again, totally focused on men in all the studies, is the bone marrow density changes. And so women initiating it had less decline. So this is the TDF. These are treatment naive patients, and you can see the big dips. You can see just smaller ones, which is statistically different in the spine and the hip. And then those who are virologically suppressed, you actually see improvement in their bone marrow density, both in the spine and the hip. And again, looks like men. They weren't included enough in the beginning. So this is great, though, to see, even though it had to be a pooled retrospective analysis, at least we now have this data that we can definitively say to women, this is what it looks like, if we didn't have enough previously.
On this pool analysis, always a piece of data that we would like to see is, particularly in women, the effect of dyslipidemia in particularly postmenopausal women, because staph-based regimen has worsening lipid effect, and you wonder the additional risk in postmenopausal women,
Sure.
and then you have an educated conversation with your patient about the benefits of all the other points, but also the potential aggravation. We don't know.
Yeah, I don't, certainly they did not include that in this. It would be certainly a nice analysis, because that would be important to look at in our older women particularly, I agree. Okay, and then, you know, this was a big issue, you know, when the data came out of Botswana that 4 of 99, around that, had babies had neural tube defects in mothers that were taking dolutegravir. This became a big scramble, and everyone was trying to figure this out. And this was a big retrospective study, or they basically looked at all of the pregnancy data they had in the antiviral pregnancy registry, which was through July 2018, over 20,000 people, and then the prospective national cohort of pregnant women living with HIV of just over 8,000. And so I'll just take you through, I mean, the very big key here is this: no neural tube defects. They looked at, you know, different times, periconception, first trimester, second and third. They did still look at defect cases and other CNS issues. Certainly, you know, comparing to the data that the Botswana data, no neural tube defects was obviously very important to see. In this other group, they didn't specifically look at neural tube defects, but they talked about birth defects, stillbirths, preterm, and they were between, INSTI exposed babies and INSTI unexposed babies that were matched, and no difference between the two. So, and what they say, but you know, I don't know why they didn't include it. No neural tube defects among the birth defects were reported, but they obviously don't capture it here, so I don't know how formal that is. And what the authors concluded was that definitely additional surveillance data is needed. That's not, you know, this issue isn't done. But in this big retrospective analysis, there was no evidence of higher birth defect rate among women who are exposed to INSTIs. Yes, Gigi? Oh.
Thanks for considering talking to me before I had the microphone.
Yes.
In talking to Andy Hall, our perinatologist that works with our women, he's when this first came out, he said you have to know the background rate of neural tube defects when first hearing about Botswana. And he was saying that in some parts of England, the neural tube defect rates are very high, and in other parts in England, it's very low. And he said it's impossible to interpret the Botswana data without knowing their background rates.
Yeah.
So I think that's just goes along perfectly with this, in that we have very low rates of neural tube defects, therefore we have seen very few.
Right.
So these were the poster presentations, but there was actually a very nice symposium presentation by Lynn Moffinson that reviewed the totality of what's known about neural tube defects as the background rates, and then in the context of different antiretroviral drugs, not just integrase inhibitors. So I would encourage you to you can go on the website, the CROI conference website, and click on webcasts, and you can pull up that presentation and just watch it. It's 30 minutes, but it's very good and very comprehensive, and basically makes the point that how many observations we will need over the course of time in order to definitively say whether there's a higher background rate with integrase inhibitors or not. And it's a very measured presentation, so, and very comprehensive. So it was good. Lynn Moffinson, she was the head of NICHD and retired a couple of years ago, but she very involved in child and adolescent medicine and did a very nice review.
We can send that out on the link after. But it's also great having a CROI organizer here. She stays right on top of me. So thank you. I appreciate it. So again, sort of in a little bit of a different direction, and then I'll get into HIV prevention. I told Davey I was going to be done by 10 of, and so I'll still try to get through it. But I think this was just a really great study. Stream point of care viral load testing. It was done in a clinic in Durbin. Adults who were presenting for their 6-month follow-up and first HIV RNA test after starting ART. So they were randomized to get point of care testing and then same-day counseling with basically an RN equivalent, and then or lab testing plus standard care from a nurse practitioner, MD, and I believe they don't get these results until the next time they're back, because I don't think there are ways to communicate them. So these are people actually getting those results that day. And the primary endpoint was retention and care with low viral RNA. And then they studied some other things, including healthcare, doing a healthcare utilization and cost analysis. So this was just, to me, so cool. For people who got this was the outcome at 12 months. The point of care test, 90% had a viral load less than 200 and retention and care, compared to 76% who got the standard of care, the lab test, and return. This is highly statistically significant, which I think a lot of us have experienced when we talk to our patients actually with the values in front of us. It's very helpful. And a point of care test, obviously, with a viral load when people either never have seen them or, are starting to see them, but get them that day and counseling can occur, obviously works here. And then the median time to enter the result into the health system, 0 versus 2 days. At 12 months, more than 60% of the people receiving the point of care testing had been referred to community-based ART delivery programs versus only 25% receiving standard of care. And then just in terms of cost, the cost, they didn't say if it was statistically significantly different. I'm going to say it doesn't appear to be, but it's certainly it's the same or maybe a little bit less. Sorry, not sure why they didn't include that. But what's definitely less is the number of clinic visits they had. No, sorry. Yeah, sorry, comparing these to this, sorry. So fewer visits in the point of care testing compared to with the lab testing. Gabe?
So a testing that tests for recency or more recent or earlier stages of infection are particularly helpful in a population that has a high frequency, high incidence like ours, and so do you know anything, Jill, about this Durbin Clinic? Are they, so they have like a large prevalence or,
Oh, for sure.
Yeah.
These are people who already had been diagnosed.
Oh.
Yeah, no, it's okay. Yeah.
Gotcha.
This was their 6-month follow-up.
Gotcha.
Yeah. Yeah, I mean, it would be interesting also to do it same day. I agree, and maybe that's something they will start to move towards. All right, just in the interest of keeping us on time, I'm going to get to the HIV prevention side of things. So the big study that came out, we're one of the study sites, is Discover, which compares FTAF versus FTDF. So FTAF is the Descovy and FTDF is Truvada, but I'm gonna say FTAF versus FTDF. So they included MSM and transgender women, one-to-one randomization. Everything was placeboed. So they didn't know which arm they were in for 96 weeks. They did have a 40, I'll show you about the primary analysis. Sort of standard entry and Q12 week is pretty minimal study in terms of what was happening. They were very short visits as opposed to what's happened in the past. Primary analysis was when 100% had reached week 48 and then 50% completed week 96. I believe what we have, why this was presented was 50% of people had reached the week 96. And then they could open label switch for 48 weeks. So a couple of things that were important, they had to have high sexual HIV risk. So pretty strong criteria to be in this study. And it was done in cities with high HIV incidence, 94 sites, 11 countries, US 60%, and then a little distribution in Europe. Nothing in or African or Southeast Asian countries, and then non-inferiority margin. I do want to point out, I'm really happy about this study. I'm glad we have it. I think there were several flaws in this study that leave me with some unanswered questions. So they only included 9% Black individuals. And not that, I mean, well, it could work differently in Black individuals. We know that that's happened for other medications. We know that can happen. I think the bigger issue is the mistrust that has occurred in this community where they've been, this medication has been pushed. FTDF, it won't hurt you, it won't harm you, your kidneys are fine, your bone marrow is fine. Oh wait, we have a better version now. I think that can make a lot of people suspicious, and I think this was a mistake. Also, transgender women that were included, 1% to me doesn't include transgender women. So I don't think you can draw any conclusion about transgender women, although they did draw a conclusion at CROI, saying that it was safe and efficacious for transgender women. So just wanted to make a couple of those points. And 23% had prior PrEP use. Initially, they were going to not allow people that were taking PrEP to be in the study, and the community fought back about this. So you had a lot of people entering who'd used PrEP, and a very high-risk population, 41% had greater than 3 receptive condom-less anal sex partners. So the big news is that it was non-inferior, but they weren't actually able to show it by what they were trying to do it because there weren't enough infections in the study, which was sort of what was expected. And then they planned for their backup was basically that there were more infections in the TDF arm than the TAF arm. And they did this with some nice statistics that make it sound good, but they knew they had this plan in place. They knew there weren't going to be a lot of infections when you're comparing a drug that you knew worked really well to a drug that they thought was going to work very well. And non-inferiority margin works fine. So it's non-inferior. I would say it's non-inferior in white MSM. I mean, maybe you can include some other groups. I just don't think it was very well studied in the other groups. So people who got infected, I think, so a few of them had suspected baseline infections, and these resistance mutations in TDF were suspected to be at baseline, but they did not, these were not archived. I don't know if they're going to be going back and looking at that, but I think, no surprise to us, individuals, well, the slash lines are where the DBS numbers were low. You did have a couple of people who did still have high levels, 1 and 1 in each group. And I'm sorry if I didn't say the number, maybe people saw it, the number of people that were enrolled in this study. Oh, and it's huge numbers, 5,000. So, obviously a lot of people in this study, just some limited groups, very sexually active groups. So the point is, clearly, this was a group who could get HIV, as evidenced by the amount of gonorrhea and chlamydia that was seen in both arms, a little bit less syphilis. So, you know, this was a group that should, you know, could have been getting HIV, which, you know, shows that these numbers really are low in that setting. And then the renal safety and the bone density, you know, all of them are statistically significant. GFR stays more stable with FTAF, and then the same thing with the retinol binding protein and beta-2 microglobulin ratios with creatinine also, and those are more stable. So, and no discontinuations, or I'm sorry, there was true discontinuations due to kidney stuff with FTAF. I don't know exactly what those were, and no Fanconi syndrome, but one in the other arm. Bone safety, same thing. We're seeing, you know, much better results here, and this is at week 48, sub-study of 383 people. So this was sort of they wanted to compare this because they had no, obviously it wouldn't be reasonable anymore to have, or be unethical to have a placebo, a group that didn't get PrEP. We can't do that anymore. So basically they used CDC reported surveillance data, and they calculated what the background would look like in all of the sites that they used if people weren't taking PrEP, and that was going to be an incidence of 4 per 100 person years, and basically the incidence rates using these were 0.08 per 100 person years and 0.45 for TDF. So obviously substantially different between here. These are no different. And what they said though, and this obviously sounds amazing if you can say that there's a 98% reduction using FTAF relative to the background. And it really does, if you're saying this to a patient, I can imagine saying 98% versus 89%. It sounds like someone would want to go with the 98%, but this is not statistically significant. So, I mean, this was a big study that, you know, that obviously came out. The conclusion by a lot of people is it works, but certainly, you know, taking costs into consideration and all those things, right now, FTAF would really be for patients with pre-existing kidney or bone issues, or where you were suspicious that could happen. This isn't something right now, you know, you should be rushing to do. I think there's still some stuff to be worked out, but I'm curious if anyone has any thoughts who's there or read about this, or maybe we don't have time, we can talk about it later. Yeah, again, great study. I think there was a rush to get this enrolled, to get this moving, and I think that's why we see some of the things we see, you know, not very well demographically represented and not well gender oriented either.
Have you tried to switch anybody over yet based on this data?
No.
I'm just curious if insurance will push back before the labeling.
I mean, it hasn't come up. I mean, I'll say me. That was myself, and I guess I have a good number of PrEP patients at this point. It has not been an issue. I see renal issues have not been a big issue. Maybe Dan was. Okay. Have you, Dan?
Well, the question I had was related to rectal tissue in terms of, you know, the initial thoughts were that that TAF would not, maybe the levels are going to be lower in the rectal tissue, and that was kind of postulated as perhaps it might not work.
Right.
You know, so I haven't heard anything about rectal tissue levels, et cetera.
No, why would they be studied if they were lower before?
Yeah.
I mean, I think this just shows, sorry, I like Iliad, I'm just being snarky this morning. No, I think the idea is that perhaps the tissues matter less than what we had posited before in terms of prevention, and that it's more, you know, whatever, you know, getting to the lymphocytes, you know, getting in other places matters more. You know, we have seen some cases where there was the one case out of Amsterdam where they sort of posited that the person had so much sex, like this person had great levels, they had, they were wild type, and they posited that there was so much sexual activity that perhaps it just broke through, and that was, the primary area. Maybe we'll end up seeing some more of those if the rectal tissue does matter in any way, but I don't know for sure. I mean, it's a great question. That was what I was nervous about this too, but it doesn't seem to be an issue here. But thanks for bringing that up. Okay. I think I'm gonna, well, just really quickly, and I don't think this is gonna surprise anyone, but basically they found a dose-dependent decline in bone marrow density in people taking tenofovir or taking FTC TDF. And basically they looked at people with different number, based on what they were, what levels they achieved with their dried blood spots. You really see that as someone, so this is the mean bone BMD change, and for someone who's taking it daily, they have the greatest change. And it really is a very clear dose-dependent decline. I think this just comes up as, I mean, this is important as providers, how you're going to counsel patients where, this is what they have to take, pretend FTAF doesn't exist, and, do you counsel someone, just, take fewer pills or on-demand dosing? We don't have those recommendations. Those aren't FDA approved in the United States. I don't think they ever will be. I'm making a big, broad statement, but how do you want to deal with patients specifically knowing this? PrEP persistence. It's not good. I think this is one of our biggest challenges in the field of HIV prevention is getting people to stay, to continue on their PrEP, which is why, having navigators and people who are specifically looking for people when they leave or they go to figure out what's going on and help them. This was a retrospective analysis of looking at commercially insured versus Medicaid patients, many more commercially insured compared to Medicaid. And they define persistence as a length of use from initiation to continuation with a gap greater than 30 days before refills. Factors associated with lower persistence were female sex, younger age, residing in a rural location, Black race, ethnicity, and Medicaid, none of which surprised me. I don't know. I think sort of if I had to make a hypothesis, that would have been my hypothesis, and shows that, we still have a lot of work to do. And of course, a lot of this pops up where our United States epidemic is in the Southeast. So we really need to tailor interventions for priority populations to improve persistence. Then there was a specific study in Atlanta of young Black MSM looking at PrEP uptake and persistence. It was prospective observational cohort, almost 300 individuals, 16 to 29. Participants were studied for 24 months. They came in every 3 months. They had, these were patients not on PrEP to begin with, but they had standard testing as if they were going to go on PrEP, plus urine drug testing, so tenofovir drug testing, not testing for illicit drugs. And then they got an HIV, HPV, the nucleic acid test, so the equivalent of the early test. It might be the early test. I'm not sure. Maybe but anyway, just a NAT. And it did include an optional PrEP program, and they were offered it at every visit. They had clinician visits. There was a PrEP navigator to help with access, lab scheduling, prescriptions, and there was no issue. The idea is there'd be no issue with insurance or accessing the medication, paying for lab costs and visits, which any of us who are dealing with this know that that's one of the biggest issues in getting people on and staying. And discontinuation was 14 days off of PrEP. And then considered final if they never restarted it. So they looked at first and final PrEP continuations. So 42% started PrEP, and 63% discontinued at least once, But there was a good amount of time, median time to the first discontinuation of 219 days. But that's basically, so that's about, is that 8 months? I don't know. Right there, which is sort of what I think what we, without looking at this is what we've been seeing. 6 months is sort of a key turnaround time for patients. And then 31% had a final discontinuation, and the median time of that was over a year. And then just what was associated with discontinuation: younger age, fewer sexual partners, an STI in the past 12 months. That makes me always a little bit nervous. And then what was interesting in this group was that marijuana use was associated with more discontinuations and final PrEP. But the authors made a point to say that risky alcohol use and illicit drug use was not significantly associated, which has been shown, and at least in the studies that we did here, that heavy drug use and alcohol use did not affect people's ability to take or stay on PrEP. But other groups have shown different things. So I was intrigued by this marijuana finding. Immediate PrEP is a new and exciting way of giving PrEP. We are doing it here. Susan Little and her group are doing it here. This is a review of what's been happening in New York City early January to June 2018. And so basically what they did was people would present to a sexual health clinic, and if they had any history any history of kidney disease or HPV or bone issues, kidney issues and kidney issues, HPV, or any signs of acute infection, they were delayed. And those who had none of those things were started immediately. And so then what they did was, once they started people, they looked to see who actually had real medical contraindications. And in the delayed group, there still were some, but most of them were completely fine to start. And in the immediate group, there was barely anything. But then what's important is that, so very few IPrep patients actually would have needed to discontinue. And when they did actually start, very few of them had to discontinue it. And delaying PrEP initiation resulted in substantial lost follow-up. Probably not surprising to people. Only 35% of the delayed PrEP candidates initiated within 60 days. I think this is the direction we're heading in. Immediate PrEP, especially for young individuals, there really aren't great reasons to wait if you can get people right away. Darcy, wait, no. I didn't hear you.
Is there any data on immediate PrEP in people who use injection drugs? Because that's sort of a setting in hospitalized patients where, like, I want to start them and we don't have a mechanism.
I know
for
this
that.
is your big hot thing. I don't believe so yet. I mean, I think this is a huge undertaking. I'm sure they have data. I bet they have data on injection drug users. So we'll see some of this more granulated data, or granular data later, but not that I'm aware of right now. Gabe.
Yeah, so, I've been working with Susan, is she here?
Yes, and Gabe.
And Alina, actually, on the immediate PrEP so far. And it's interesting. This is, of course, if it can be done, it would be fantastic. But it's really going to have some real world blockades and barriers. It does, when people are started on it, in the groups and the data that we've seen so far, they do well if you get them on it the same day.
Do well, what do you mean by that?
They start the second bar, the bar on the right in the graph. If you offer them and they get it right the same day, then they start it the same day. But
I'm receiving them, and a lot of them I don't receive. So there is something about that linkage that's still very difficult, even if they're already taking PrEP. So that's, to me, am I still on this? Yeah. That's still the big issue about who continues. Yeah. But yeah, giving it to them then and there, it's wonderful. But I still think it's that follow-up piece. Remember, this is just who started it. We don't know. I think retention is going to be the big thing.
Oh yeah, I'm just talking about
just giving it to them. Yeah. Right.
I mean,
But I agree. It's so good to give it to them on the spot. Miguel.
Yeah. So modifying medication adherence behaviors is really challenging, right? There's probably very few things that I think actually do that. I think one thing that probably doesn't do it are the granularity or frequency of medical visits and laboratory testing. And so the 3-month visit testing, in my practice, I'm moving away from that for my established patients.
Still getting a test at 3 months.
No, I try and I have discussions with patients once they sort of meet a basic minimum of follow-up visits and adherence. I have a discussion what their sexual activities are, what their risk, sort of trying to risk stratify them in some amount, and increase the testing intervals to 6 months for some patients with 6-month refills. So that those patients that are on PrEP that are taking that initiation aren't penalized. So it doesn't exhaust them. And sort of the idea that there's sort of a self-selection, those are more adherent, sort of a little OCD component. And trying to, in scripts, I've been also practicing with trying to do a lot more at-home testing, at least with, gonorrhea, chlamydia, or having standing laboratory orders that they can do independent of a medical visit. I mean, I see the monitoring, I think it makes us feel better, but I don't think it necessarily certainly doesn't increase adherence. Right?
So just to play devil's advocate, you probably, I'm guessing your cohort of patients, they are obviously well insured. I don't know what the demographics are, but you probably have maybe some of the earlier adopters. I think with established patients who you feel very good about, I totally agree with that. I think what's harder is with the patients who you really don't know what's going to happen when they go out there, but are you willing to take the risk? And maybe, this is a risk benefit of go out, see how you do, and I'll see you back in, in 6 months. In the studies with young individuals, it showed that they did worse when they got further apart. I totally agree. I think with established patients, this is a no-brainer. I think what we may end up doing though is creating a greater disparity by helping, by supporting those individuals who can do it, and then the ones who can't, we still don't know what's best for them. And I don't know if it's more frequent visits, but I don't think we've figured it out yet. I agree with you though. I think with established patients, easy. I don't know.
If you're working or you're a student,
yes,
3-month visits really
are very difficult
or not sustainable.
Yeah, no, I agree. I mean, I'm doing that too, but I'm still insisting on an HIV test. But that may go out the window at some point. Dr. Morris.
Because I think that if anybody's listening, what would really help would be, if we could get self-collected pharynx and rectal specimens at the labs, you know what I mean? Because if you want to do that remote visit and send the lab, you're missing the rectal and pharyngeal STIs, and that's where I feel guilty about it. But if we could get the labs to do that.
Wait, Miguel.
So I've been doing that, and to the annoyance of my lab. And so what I do is I provide them with collection kits, instructions, and out the door. And my counter argument, because there is some. The labs take it and run it? They have.
Our labs will not.
They've rejected it initially, and then I've stomped and because like urinalysis those are self-collected. So we have precedents for self-collected tests, and how hard is it really to use a swab? So I have like maybe 5 patients that are really high risk individuals, and they self-collect pretty frequently.
I think we'll go in that direction ultimately. I think that'll work. And just I know it's 5 after, so whoever wants to leave can. No, it's okay. Anyone can get up and leave. I love it. I just thought this was cool. Kaiser, Northern California, tried to do a prediction model to find patients in a system. Their point was, can every doctor think of when someone should go on PrEP? Probably not. It's not always at the forefront of their minds, even if it might be at ours. So they looked at 60 different demographic, clinical, and behavioral variables to predict HIV risk. And basically they they used this regression model and machine learning to predict how many incident cases they'd have, which was a little over 400. Their final model included 41 predictors. And I thought, and some of them were interesting. I think black race, home zip code probably would make sense to, you know, based on what we know. But urine positivity for methadone, use of medications for ED, I didn't necessarily think of, although they make sense. These are some that were included in their model. And basically what they did, so they looked at all of these incident cases and ran, you know, looked at these they ran their predictors. And the one with 41, they caught 66% of male HIV cases. And with every model that they did, they basically ended up with this for women. And the bottom line is this is, at least in this system, they had no idea how to predict who's at risk for women. And for anyone who's worked with me on any study I've been involved with, they know that, you know, for our HIV prevention study, it's been one of the hardest things to do. But this is still pretty cool that you can teach your EMR to, you know, to do an algorithm that would help doctors. And what's interesting of this, they used the 1% of scores, which identified 6,076 candidates because they had a huge number. 92% were not on PrEP. So obviously it's a great place to start with patients, to just know I could ask this person. And then this is just really fast. I'm writing an article about this. So this is such a big issue that I don't think is, I mean, we're probably doing a great job. So I'm always preaching to the choir here. But they did an entire session on the concept of U equals U, that, you know, persons who are virally suppressed cannot transmit to their sexual partners. And they went through the history of how that evolved and what situations would you not feel comfortable doing it? Like, you know, would you give someone PEP if their partner was HIV positive and the condom broke? How would you feel about that? Would you do it if a patient said, oh yeah, all my partners are on PrEP? You know, what do you need? What's the barrier where you feel comfortable with this? What is the community perspective? And they have this great community speaker. I encourage you to, we'll send out 2 things to watch. I think this is really important to watch. The community person said she thinks it is an ethical duty for doctors to talk about this, to explain this to their patients, and that withholding this information is really unethical. That, you know, and people should be aware of this. And then they looked at what it would look like at a population level impact, which is huge. But what they still said in this, it would still not get us completely to where we need to be, and that combination prevention strategies are still part of it. Yeah, so I encourage you to watch that. It's really very interesting. Thank you, Connie, for slides and also helping me here. I got slides from a few different people. I like Dr. Wooten, feel very strongly about Paul Sachs, especially when I'm trying to do a review. And then all my young women warriors who keep battling on. Anyway, that's it. I'm sorry I went over. I was trying to do better, but it's hard for me. I'll be here. Oh, do you want to just, oh, hi, Jessica.
Hello. Hello, I'm a resident. I have a question though. I figured while I'm here, I might as well ask it. Are you aware of any efforts to do iPrep at the VA? I know it's probably the wrong setting for that, but I find that there are more barriers to getting folks prepped at the VA.
I'm going to defer to any of my, yeah, this is probably some, yeah, thanks.
No, I just know that, so Davey just left.
Yeah. Oh, I don't know if Susan had ever, if you had proposed to try to do it.
Yeah, no, I think he was talking about actually doing something like that. Yes, I think, yeah, I think the answer is yes.
Yeah, I mean, they got PrEP moving very quickly at the VA, well before we were doing it at UCSD. I think they have the power to do that. Dr. Tillman, it's so lovely to see you.
Likewise. It's been a while. I just had a question regarding the iPrep study in New York. You said they did NAT on everyone.
I didn't. You probably read it somewhere.
Or I was just wondering what kind of HIV screening they did. I thought you had said they.
I didn't.
Or maybe that was a different study.
For the persistence, but no. I'm glad you caught that.
So they just did antigen antibody
so anyone.
Baseline HIV testing.
So anyone. This was just an antibody test.
Okay.
There is something about in New York City, and now I'm forgetting it, related to NAT, where they have to do it at a certain point, and now I'm forgetting what it is. That was that you're thinking of this study where they did it here for the young Black MSM, but there is something related to this, and now I'm blanking on what it was, because this was just, they got a rapid antibody test. It was quick, and that was all that they did. So at least they did an HIV test. I should have said that. They weren't just popping anyone on.
Okay. Do you know if other places are just doing standard HIV testing with the antigen antibody assay, or a lot of places that have implemented iPrep, are they using any kind of NAT screening? I was just thinking in terms of cost,
Sure.
you know,
I think
and if they do any kind of pooling, if they do any NAT screening.
I know that places are all, they want to follow the New York City model. They're doing this in San Francisco too, maybe at Prep. I don't know, I'm looking at Gabe because he's got more inside scoop there. I know they do iPrep there. I know they have a lot of experience pooling. I'm gonna guess that's what they're doing there. They obviously still have to do a point of care test, you know, when people are there. And the problem is the point of care antigen antibody tests are not good. So we are still using point of care antibodies. I think that's, to me, that's really the next biggest thing that we have to have is a good antigen antibody test. I'm supposed to talk to you actually, because we just talked about something yesterday related to antigen antibody tests at UCSD, and them being very poor. But anyway, just the test. So I think that's the big issue, but I mean, this data looks great. I mean, they didn't, again, I think there's a lot to analyze. Who knows if anyone went on to seroconverted was already positive at the time. I think they took, acute HIV very seriously. That might have been it. And anyone that they suspected acute HIV no, but you would always do that. I'll have to get back to you on that. There is definitely something related to them doing the nucleic acid tests in New York City.
All got required laboratory tests, and then in both groups.
But when they came back.
No, clinical assessment. So
that's just an antibody.
But they still got antibody.
They got their antibody. They got their antibody test there and then. And then maybe that, okay, so maybe that's it. So as part of this, and this is different than other places. Yes, thank you. So they saw the antibody test, because obviously if the antibody test was positive, they weren't going to start them. But they also, the rule in New York City is that everyone gets a nucleic acid test, but I believe it's pooled.
And so,
yeah, thank you, Connie.
Just to clarify, so in both groups, they got what we would consider to be standard NAT testing at the time they were seen. It's just that the immediate group got started without knowing the result of that. But what you can see is in the immediate group, only 0.7% of those had to stop PrEP because of something else, meaning potentially another medical problem or because the test suggested that they shouldn't be on it.
They didn't talk about here, but you did say standard clinical assessment. It's obvious it's not standard of care anywhere, but in that's New York City, and and thank you for bringing that up. They they specifically said as part of this program it was mandatory to have the nucleic acid test, and I believe in San Francisco they're doing the same thing, but it's cool there.
Yeah.
If I'm wrong, I'll get back to you on that. But thank you. Yes.
They'll retrospectively or retroactively know the results of the test and bring the ones back who have some abnormality of the test that requires they stop PrEP.
Right, and I would say note here, absolute contraindication. I don't know if those absolute contraindications mean they're HIV positive or is renal disease. They didn't go into what those things were. I think again there'll be much more data coming forward soon. It's 9:15. I think it's time to get out of here. But I'll be hanging out here if anyone